I think that psychiatry has an opportunity to play a role in pain management at a variety of different levels. We are both specialist and generalist when it comes to pain management because we deal with specific consequences and comorbidities that patients with pain experience, like depression or anxiety, but we also offer a systems view of their rehabilitation and how they're going to remain functional. So that psychiatry deals with the whole person, the people in their lives, the activities that they're trying to remain productive in, and how to overcome the barriers to functioning better. At specific levels, we offer insights into the medication management for different conditions like neuropathic pain, because so many of the medicines that are used to treat that are also psychotropic medicines used for other purposes like depression or mood stabilization. We can look specifically at impacts that their disease process is having on being able to do other activities, the problems that they may encounter with medications like opioids or benzodiazepines, making that distinction between who may have an addiction or have developed an addiction and who is simply poorly treated or needs a more sophisticated regimen. At the same time, we can help people think about what is it that you're doing with the people in your life and with your environment in general that is difficult. How can we help you to be more functional and productive? How can we help you to reestablish the relationships and build that support system and ultimately become more resilient as you move through your recovery from being a disabled patient with pain to a fully functional person that happens to have pain? I think that's part of what psychiatry needs to do a better job at communicating. I think that primary care doctors are the front line. They're the most proliferous specialist who is taking care of patients, and they are trying to help us keep patients going and not having to progress to the need for more invasive, more intensive, more subspecialty care. At the same time, psychiatry really should be one of the earlier consultations that the primary care doctor brings into that team. I think if the primary care doctor is seeing a patient and everything is going well and they feel like the patient is progressing and getting more functional, that's a keep going strategy. But I think if they ask themselves, why is my patient doing better? Or my patient doesn't seem to be responding in a positive way like other patients who I've seen with similar problems. I think that's the time when you should start thinking, what have I missed? Who can I help me? Or who can help me do this better? And oftentimes what is missed is something that is in the larger purview of psychiatrists. A depression, a behavioral problem of some type, a systems issue in their life, a stressor that they can't cope with. That's a time for the primary care doctor to say, I'd like to get a more comprehensive picture of you, the patient, and this is who I'm going to bring in to do that.